Hi, hello everybody. Hi, this is Yi Cui. I'm a professor at the Stanford University in Material Science Engineering. On behalf of all my board members in the Stanford University Chinese faculty and family club, I would like to welcome all of you to attend our webinar related to the fifth wave of COVID-19 pandemic. Let me start by inviting our board member, Professor Xiang to the stage. He will be moderating the whole webinar. Let me do a really quick introduction about Xiang. Xiang is a key member in the Stanford Chinese faculty, the cohort. Xiang is a medical doctor and PhD in our Stanford hospitals. He has been certainly playing leadership role, not only on his research, but also organizing Chinese faculty and family to all type of events. With that, let me pass this to Xiang to organize, to moderate today's event.
Thank you, Yi, for your kind introduction. If you're okay, can you put up the slides on the screen again, just to share that? Welcome everyone. Good afternoon. Thank you for spending your beautiful Sunday afternoon, an hour and a half with us today, with our speakers, Dr. Wang. Today we will be spending an hour and a half on, kind of brainstorming of what's going on in our society regarding COVID-19. So this meeting will be starting with a lecture by Dr. Wang, an excellent lecture, I can guarantee you, and followed by a question and answer. And I personally have prepared some questions, and then also got a lot of questions from our audiences already ahead of time before the meeting even started. I think it will be a very heated discussion, or a very helpful webinars, and hopefully your 90 minutes is well spent with us today. So thank you again. So let me first start by introducing Dr. Wang. So Dr. Wang, she is an infection disease specialist. Dr. Wang graduated from Peking Union Medical University in about 21 years ago in Beijing. She then came to America and she received her residency training from Huron Hospital of Cleveland Clinic Health System. Later, she received her infection disease fellowship training at St. Louis University Hospital. Dr. Wang currently practices at the Missouri Baptist Hospital in St. Louis. She's obviously specialized in infection disease, which includes COVID-19 virus. So basically, over the past almost 2 years now, she has been in the front line, literally battling, treating COVID-19 virus infections for many of those patients. She has accumulated many firsthand experience managing this condition. So Dr. Wang is a very important lifetime members of the Society of Chinese American Physicians, which I, along with other physicians, founded at Stanford 7 years ago. Dr. Wang has been giving lectures about COVID-19 over the last 6 months or so for many communities. We're honored to have her to spend her time with us today and to share her experience dealing with COVID-19. So here you go, Dr. Wang, please take over.
Hello.
We can hear you.
Good evening. I would say good afternoon. Actually, here I'm evening time in Missouri. And it's what an honor to be here to discuss with all of you about what we are facing currently in COVID pandemic. So today I'm going to talk about it when our fifth waves of surge of COVID is coming. So this is my disclosure. And so I still remember 1 week ago, Dr. Qian is trying to ask me what topic we should use. We're talking about prepare for this wave, fifth wave. But now I took the, this is Johns Hopkins website of the current outbreak in the whole world. Of course, this green line is United States. You can see just in 1 week, we already dived into this fifth wave, this fifth surge. And it's just coming so quick. Luckily, as I know, California is currently still in a stable situation, but in the state I am in right now, we already have Omicrons. We already have significant increase of our COVID cases and hospitalization. And we already live with COVID in the last almost 2 years. And so what we're facing new right now is what is unique is what I try to discuss today. So this is the research project from Washington State. Of all the Washington states, their statistic of current COVID cases. And you can see that when the wave comes, you can see this blue wave is the breakthrough infection. This is what we're facing. And since last year in December, we start to vaccinate about, up to now, about 20, I believe, 200 million of people vaccination in the United States. And when Delta wave comes, we start have more and more breakthrough infection. And right now we are facing the breakthrough infection already counted as 30% of all the cases. And this is everyone is facing, as I know, as in California, the vaccination rate is very good. Actually, it's much better than us. Average about 74% of adults already get the full vaccinated. So, so is this Washington State. They are similar as California. So when the breakthrough infection is coming to us, how we face it, how we deal with it, is the main topic I'm going to talk today. And so here is more detailed data from that research project of Washington State. So up to November 20th, there's totally 4.8 million people fully vaccinated there. And you can see they found out totally about 78,000 of breakthrough cases. If you count as a mass, it's about 1.6%. If you get vaccinated, you have the chance to get breakthrough infection. And in those breakthrough infections, 87% have some symptoms, and about 8% have the severe disease, need to be hospitalized, and totally 775 people died of COVID from the breakthrough infection. If you count, actually, this rate is very, very low. It's about 0.2 per 1,000 chance. So this is already lower than influenza mortality. So usually when we talk about how to prevent this disease, we try to clarify what our goal is. So in United States, it's almost, I will be honest, it's almost impossible to completely prevent infection. With the waves comes and goes and happen everywhere in the country and in the world, almost every family in the future, in the next few months, probably will have to face directly encounter with this virus. This is a very big chance and we're living with it. So one goal is prevent infection. This is very hard. another goal is prevent severe disease so that we decrease mortality, we decrease hospitalization. Of course, the best, we don't get infected so that we don't get long COVID. So when we reach here, I want to share a case with you, what I encountered recently with my close friend. I believe a lot of you probably encountered too and heard about General Powell, who was fully vaccinated, but unfortunately he died from breakthrough infection. And one of my close friend, who is a neurologist here, she's part-time worker and mainly do telemedicine at home. So she tried her best to do not encounter patient cases. And she have different family members, include her mother, grandma, who is immune compromised and is a kidney transplant patient who received transplant a few years ago, who is very stable, and have an 84-year-old grandpa. And then she had 3 kids, and one of them, 11-year-old, at that time have not been qualified for vaccination. That was 2 months ago. And also her husband, and then a 14-year-old, then a college student. So her mother one day so she feel very tired. Her mother just very tired. She don't know what's going on. So she told her mother, grandma, just rest. But over the weekend, grandma developed cough and a fever. So they found something wrong. So she went to Walgreens to buy a rapid test kit. And on that day, on Monday, she and her second kids, 14-year-old, and her father both have present with fever and start cough. So they checked, and 4 of 6 of them are positive. So they did have a breakthrough infection at home. Then on Tuesday, mother started have severe fatigue and shortness of breath. So she was sent to hospital. At that time, she already have oxygenation about 84%. So she was admitted. So at that time on Tuesday, she called me. She said, Jin, what I can do for my family, with this situation. I told her, so get your father to get monoclonal antibody as soon as possible. So luckily her father reached the primary care and ordered monoclonal antibody second day and receive it. So in 2 days, this old gentleman turned around, didn't have any fever, all the symptoms resolved. Then my friend, she is positive, her 14-year-old was positive, both have very mild symptoms, so they didn't get any treatment. After 3 days, they are fine, they are on the quarantine. Her husband is fine, her husband is taking care of the mother. Unfortunately, grandma is the worst case. On the Wednesday time, her oxygen needs need 15 liters support. Then she ended with respiratory failure. Then eventually stayed in the hospital for 3 weeks, struggling with treat with all the remdesivir, dexamethasone. Then she complicated with a lot of secondary fungal infection in the lung. Eventually they have to give up, and so the grandma died. So why I want to share this story with you is because a lot of you might face in the future, and you know what we should do when we are facing those conditions. So, so actually, I think when we have those breakthrough infections coming more and more, what we should do, our president actually last week gave us a very good list of new action he's going to take. I want to share is most important is the first 4 of them we'll discuss today. First is get booster for for all adults. Second is vaccination to our kids. Third is get more at-home testing kits. Fourth is get stronger public health, continue with masking and social distance. And this slide is trying to share with you for the breakthrough infection, what the vaccination will do and how it looks right now. So this is from CDC from yesterday. CDC data is a little bit delayed. So from here, you can see the solid line are all fully vaccinated, and the dashed line are unvaccinated. So here you can see if unvaccinated, actually the young adolescents, they didn't put kids there, and adolescents have very high infection rates. Right now, they have more than 1/3 from the young people. And also elderly above 80, because their activity are very limited, so they are not that much infected. But for breakthrough, this solid line, you can see almost every age, like include 20-year-old, 30-year-old, they have very similar breakthrough infection case, like 80-year-old. Only like adolescents have a little bit less. This is for the infection. So the vaccine for every age, they protect against infection, but they have similar effect of different age group. And next slide is of the death rate of the breakthrough. You can see with vaccination, we can decrease the mortality significantly for all the age group. But the who really suffer from breakthrough is the 80-year-old, this purple line, and then this pink line of even above 65 have some chance of dying from breakthrough. And all other age actually already be very well protected by vaccinations. This is gets through the Delta. And so the numbers down there tell us about vaccination. Fully vaccination can protect most of us about 14 times less to get the death, and 6 times less chance to get infection. After the breakthrough infection, how different age of population develops severe disease. Actually, we got a very nice paper published just 3 days ago. This is from Yale Medical Center, and they showed us from August to October, just 3 months. They have the statistic of all the uninfected and unvaccinated on the top, and the vaccinated population, how they're hospitalized with deaths and ventilation. And you can see if you're not vaccinated, a lot of young people, even 30-year-old, they can die. And a lot of them on ventilator, even for 20-year-old, 20-something. But if you're vaccinated, this young people population up to 60-year. If younger than 60-year-old, you have much less chance of death and almost, no critical disease. And but above 60, still have a lot of chance, some chance, not a lot of chance, some chance of breakthrough cause death. And why have we have this breakthrough is because the vaccination efficacy is decreased, unfortunately, after 6 months of vaccination. So there's a bunch of study, close to 10 different studies in the last few months in different countries, and summarized how different vaccination decrease their efficacy. Usually when FDA approve a vaccination, they want the efficacy at least 50% above. And like flu vaccine usually have efficacy about 60%. And we know as Pfizer and Moderna at the beginning have like 94, 95%. But after 6 months, and Pfizer is around 40%.
What's the difference between a child that gets into a top tier school versus a
And,
lower tier school?
Moderna is a little bit better and have around 70%. And this efficacy decrease actually is real related to different variants. Later we'll talk about variant 2. And they have the, here, this is a study also published in Lancet and showed us this gray is the wild type and from Wuhan. And then the next one is Alpha, Delta, and Beta. And Beta have a lot of immuno escape. So you can see with Delta and Beta and the vaccination efficacy is decreased significantly. And this line is tell you they get the booster shot and they can rebuild the efficacy back and to much higher level, even for different variants. And this is the Pfizer study of the booster shot efficacy is more than 90% for after booster. It usually after third booster, just in 7 days, it will start work. And they can significantly increase the antibody level and give another like 90, get the efficacy build back to about 90. And this is the study tell more detail to prevent the hospitalization and the deaths and the ventilation. And booster can also make the difference for us. And this is Moderna vaccine study. And they showed from at the beginning, post-vaccine, you have plenty of antibodies which can neutralize about 50% of virus. So this is neutralized antibody is sufficient. After 6 months, it decreased, especially for different variants like Delta, Beta, Gamma. And after booster, 2 weeks later, they found out the neutralized antibodies significantly increased, even better at the beginning. So a lot of people currently is hesitating for the booster. A lot of friends was asking me, because they experienced some side effect on the second shot. This is very common for the second shot to get like fever, body ache, very uncomfortable, fatigue, lay in the bed for 2 days. And so this is the safety data of Moderna of booster. So you can see they compare this study 301 is the Moderna phase 3 original study. So they showed that the patient have like side effect of pain, erythema, those things, swollen. And actually you can see here, booster is on the left side. So they are very similar, like the second shot of the side effect. And this is another more detailed, different side effect of fever or headache, and they're very similar. And actually a little bit less, my personal experience, I had a little bit less of like fatigue than my second shot of my third shot. So a lot of people also talk about mix and match, like mix different vaccine. And actually this is a very good idea. And they currently have different studies of Pfizer mixed with Moderna, also the adenovirus vaccine like AstraZeneca, and JJ mixed with mRNA virus, mRNA vaccination. And those all have very good effect. They basically can build up the immunity, include antibody, also T cell immunity very efficiently, even better than before. Also have a lot of people said, oh, I already have infection and should I get vaccine? I will say yes, because infection, they found out infection, especially very mild or asymptomatic infection, they do not make antibody effectively, especially on elderly population. And they could make different antibodies. That's their benefit because they're natural. So they can make all panel of different antibodies to nuclear protein antibody to surface protein antibody. So they are very broad, but their titer is not very high. So so they have the previous study, if you have an infection, it's similar, have the efficacy to prevent reinfection like Johnson & Johnson at 70, around 70-ish of prevention. But if you get vaccine, again, the effect is even much better. Actually, they have the best effect, even compared with booster. So whoever get infected, then get vaccinated, especially if they have 6 months apart, they have the best protection. And usually natural infection produce those antibodies, they also last very long. They last, from current study, they found out last at least 9 months. So that's the benefit. So I would highly recommend all the previous infected person also get a vaccine. And another common question is people usually ask me, like especially like healthy, like your 40-year-old, 30-year-old, they are hesitating to get the booster shot. And because actually a lot of young people have more side effects than elderly when they get second shot. So they suffer a lot. So under those conditions, they were asking, should they have antibody titer test? That's a very good question. Currently, FDA do not recommend antibody titer test to follow up your previous vaccination. But I believe this might be a future change and future development, because right now we do see different people can make different titers. So currently the antibody titer test after vaccination usually commonly ordered by LabCorp or Quest Lab, and they're semi-quantitative SARS-CoV-2 anti-S IgG level. And how much is enough? There's no definite answer right now. Recently, there's a study, they analyzed those titer. The unit is international unit per ml. And they found out for this study was run before August. So it's before Delta. And they found out if your titer is 10 above, you have 78% of protection. If you are 100 above, you have like close to 90% of efficacy protect you. And actually most of people after 2 doses of fully vaccination, their titer from the current study found out after Pfizer or after Moderna, most people antibody reach around 800, even 1,000 above. So if you still have that much and it lasts very long, you may not have to get another vaccine, which causes you a lot of side effects. So I think this is kind of personalized discussion. And also for some people, like I have another colleague, her wife, his wife is like using rituximab, which is for her rheumatoid disease, and which knocked down all the B cells. So she had a 3 times of Moderna and her titer is still 0. So under those conditions for immunocompromised patients, whether we I think this title check will be valuable, because in the future, those population, once you really need to protect them very well, the family have to be very careful. They should avoid, big gathering. If really grandma have to get a gathering, probably everybody should get a rapid antigen test. And then whether they should get a prophylactic monoclonal antibody every month to protect them. This is, it's a future study area, and it's possible because now there's some monoclonal antibody for post-exposure prophylaxis use on immunocompromised patients is already available for in different areas. So next topic I'm going to talk about, that in the family, if there's a high-risk patient, I really think all their family members should be vaccinated. And because high vaccination rate and high family member antibody titer will really protect against the infection. And so a lot of discussion about children, whether they should get vaccination, because as all we know, children usually have very low mortality on COVID-19. But currently, this picture shows us children and adolescents become a big part of our pandemic infection. 1/4 of the cases are from children. And in the last 2 years in the United States, totally 700 deaths from COVID for children. And children also get long COVID. So there's research about the percentage of the children. So for adults, about 40% to 50% people will get long COVID, involve different like neurological symptoms or cardiac disease. Children actually are similar. They are close to, you can see here, they are also close to 30 to 40% could potentially have long COVID symptoms, especially for like neurologically or like fatigue or mentally, they will be affected. So this is a problem. That's why even COVID won't cause children severe case or death that much as senior, but they will also suffer from long COVID. This is another reason we need to give children for vaccination. And so this is just a statistic in Bay Area, how many children get vaccination. You can see only 10%. So we have a lot of potential work to do. And for the children, the Pfizer vaccine have efficacy, you can see have 90%. And its safety panels, this is how safe for the children. And they are very similar like young adult. And children mainly get the side effect is here, fatigue, headache, and muscle pain. And they don't have too many fever. So if you have kids sometimes get vaccinated, they complain like headache or muscle aches. This is common, don't get panic, and you can give them some Tylenol to get over with it. And for adolescents, we also, they have very good efficacy of 93%. And they actually, COVID vaccine can make them have almost no, prevent the critical and severe disease very well. And for the adolescents, most common topic people was worrying about is myocarditis. So for current data, the chance of myocarditis is most commonly happen on young male. And young male usually around 17 to like 25-year-old, around this age, they have most chance. So totally in the statistical CDC is 1 million people have 5 cases. And in young male, it's about 1 per 10,000. And it usually happen in the first week after the second dose. And they present with some chest pain, with some shortness of breath, some discomfort. So you can watch for those symptoms, but it's still very rare. But parents real worried about this. So we can completely understand. But before, when everybody expect COVID may eventually go away, and I think a lot of people avoid to give their adolescents the vaccination. But now we're facing is that COVID just don't go away. They keep coming. They happen everywhere. Like those conditions, you need to reevaluate. Think about if you get the kids just get infected, what's their chance of infection cause myocarditis, and versus you get vaccination and get chance of myocarditis. So this picture down there is the comparison. You can see if for young people, adolescents, they get infected, they will be hospitalized for myocarditis much more than the chance they get vaccination cause myocarditis. So this is the benefit and risk weight for you to make a decision. And so we talk about children, talk about adolescents at home. Now I want to focus on the high risk population at home or in around, who you really should pay attention to protect them is those high risk people. You need to know this high risk. Why? Because that's changed your response to take care of them. So who is most risky? And for children, is actually uncontrolled asthma and obesity, you can see here. And for adults, and actually hypertension is a big risk. Many people have hypertension. And obesity, we see so many ICU patients like on vent forever is those very obese patients. And metabolic syndrome, and also people with underlying heart disease. And chronic lung disease is not as bad as hypertension. That's is a very interesting research showed us here. So pregnancy, and so when you have very high risk population, you really need to protect them and be very careful with them. Also monitor them very closely. Like before, I give you the example of my friend's family suffering case, and so I think how we can change the result if we look back. One I can suggest is maybe that grandma who is very immune compromised, they should pay attention to her symptoms earlier. You need to realize for those immune compromised patients or elderly patients, they present very atypically. They do not present with like classic pneumonia, cough, or fever. They don't have fever. They just tired or start falling. They're not themselves or confused. Under those conditions, I highly recommend if you have high-risk people at home, you should go to Walgreens and buy this rapid antigen test. This is kind of $10 for each. And it's very similar like a rapid pregnancy test. And you can very quickly swab your nose in the front and check on it, and give results just 15 minutes. And that will save a life. And when you diagnose early, you can catch the window and to get monoclonal antibody. Like that grandma, she missed the monoclonal antibody window because she already have hypoxia. Once people have hypoxia, monoclonal antibody no longer works. So I think this close monitoring are very important. I would recommend if you have high-risk people at home, you just buy a few in Walgreens or CVS, they are available. And in the future, I heard the government, hopefully, they can give us some very low-priced rapid tests. Like currently in German, people get $1 of those rapid antigen tests. They're very useful, and they can help you to detect very early, be treated very early so that you do not spread around. Like they can use for party, for big gathering, or all those things. And so this slides actually give us a very good model of how rapid antigen test is protecting people. And it's a very interesting study maintained on a cruise ship. You know, now all the cruise ship at the beginning was shut down until this year, May, they reopened. So cruise ship have to run their business and keep away from COVID infection. Like a cruise ship is a very high risk, you know, environment. People all together in the same place and eating and have buffets all the time. And so cruise ship use different measurements, try to control the infection to get rid of COVID in their big ship. So you can see the different lines here. So they use testing, use antigen test, PCR test, then they use mask, and they use vaccine. They compare with it. You can see the most effective is this green lines. So this green lines, the light greens tell us mask on and use antigen test. Even better, you know, it doesn't matter how many vaccine rate it's covered, it have very good effect. So you can see how a rapid antigen test can play the difference for a very high risk environment gathering. And PCR test is not that good. Why? It's because just PCR test is slow. It takes, you know, many, like if you're standard, usually take, if you go outside, like 2 days to come back, and PCR test is too sensitive. And antigen test tell you exactly whether the patient is infectious or not infectious. So mask also help. And from recent study about mask, they can decrease the transmission rate. They have like 50% of protection to decrease the, also the hand wash, and the social distance is like 25% decrease on the chance of transmission. Now I want to reach the treatment is, so if you do have some high risk people, first you need to know that people is high risk. Second, you try to diagnose as soon as possible, because early outpatient treatment, the key is early. You diagnose early, catch it early, we can control virus as soon as possible. Do not make like duplicate sky high, then cause a cascade of inflammation in the body. So monoclonal antibody, it's the best if you use in the first 3 to 4 days. It is hard, but you need to, like we talked about, one is you know that person is indicated. Second, you diagnose immediately. Third is you know where to send them. As I know in Bay Area, Alameda County, they have a lot of outpatient infusion center for monoclonal antibody. Like for the place I am right now, they usually is like urgent care setting. You just call in, you ask your primary care or ask those doctors on the telemedicine, like online, to order it for you. Then they usually call in their center, urgent care center, like infusion center. You just drive the patient there, drop them off, then get, like they get infusion after 2 hours, they come out and then drive out. So it's very easy. And currently monoclonal antibody have 3 different types. And most commonly used is this type is called Regena COVID. It's from Regena company. And they have, they're still work very well for Delta. We don't know whether for Omicron. And they can cut down the severe to hospitalization and all cause of death by 70%. They're real, very good effect. Yeah, I use a lot. And then another one, it's just not available currently in my hospital, is Sotrovimab. And this monoclonal antibody is from Glaxo. And they have most recent reports, they're very good for even for Omicron mutation. So in the future, I believe this will be a very good future market going. And they have even 85% of chance to decrease the mortality and hospitalization. And then very hot topic is about oral medication. Right now, we really don't have any proved good oral medication available for us, not like Tamiflu for influenza. And just 2 days ago, the Merck, they have that molnupiravir, this medication be approved by the FDA committee voting. They have not finalized, but hopefully very soon. And so this picture just show you how those medication works. So when the COVID gets into the cell and they make proteins, and so also they make RNA, and then they make new virus. So molnupiravir and basically is used like a similar nucleic acid piece and put it there, but they are not real one. So the virus just confused, and they use those false nuclear piece to make their RNA, then they have bad quality and they die. And then Pfizer have the medication Paxlovid. And this medication actually is a proteinase inhibitor. They inhibit the virus to make protein covering. And so this is the compare of their effect. And you can see actually Pfizer, the Paxlovid have much better effect of 89%. Unfortunately, they still hang in the air, wait for FDA to prove. And unfortunately, this Merck medication is finalized, only have 30% efficacy. So right now they prove just for the very high risk population, not for everybody. And they are used in the first 5 days, but this medication have the side effect is they might change your, have genetic mutation effect. So they don't supposed to give any pregnancy or potential pregnancy people. So like currently England already proved it, but England have suggest you after you, if like female of childbirth female, if you take it, you should at the same time receive contraceptive until like take the medication 4 days after you finish the medication. And for Paxlovid, they have the booster there, ritonavir. This ritonavir is commonly used for HIV medication. And this, usually they have some side effect of ritonavir could have a drug interaction, like with Coumadin. Some of the people could not stop those anticoagulation or something. You really need to worry about these drug interactions. Usually ritonavir is fine with pregnancy, and ritonavir also have some GI side effect, but it's not as bad like usually, just 5 days treatment. So this is molnupiravir phase 2, phase 3 studies. You can see they especially useful for early detection, less than 5 days for high-risk population, and for seniors, they have much better effect. And a lot of medication like ivermectin is commonly argued on the press, social medias, a lot of people want to use it, but all the randomized control trial up to now is just controversial. If you really want to use it, you have to be in clinical trial to use it. And also like inhaled steroid Pulmicort, they might be used for. Also some antidepressant like fluvoxamine, and those might work. And colchicine or some doxycycline, that like those antibiotics might decrease inflammation, but none of them really proved it. Like also a lot of people talking about vitamins, they do not have solid evidence. And the last I want to just talk about, after all those things done, you need to remember, monitor. if you have a breakthrough infection on very high-risk people, and the currently looks fine. If they have chance to receive all the monoclonal antibody or pill medication, that's great. If not, and please get a pulse ox monitor at home, have a blood pressure cuff monitor at home, check them very closely. From this study, they will show a very close monitoring every day by healthcare service can decrease the relative risk to more than half. So close monitor. COVID is different from flu. COVID have very unique part is at beginning first week, you didn't see patient have a lot of trouble. They might just a little bit cough or fever. But a lot of people I saw, especially high-risk people, they come back on the second week. Second week usually is the most dangerous week. And either they get better or they get respiratory failure and they become very sick on the second week. So please close monitor those high-risk people if you have any at home, and even yourself, a close monitor are very important. So I will pause here, and if you have any, coming later, have any question I can answer.
Dr. Wang, that is amazing talk. We've got a lot of questions here, but some of the keywords is just kind of like, you need to get your boost vaccine. It's safe, it helps, it protects. If unfortunately you do get an infection, then you should closely monitor at home, have some availabilities at home in terms of monitoring tools. And there are therapies available, monoclonal antibodies and oral pills. Hopefully the Pfizer pill is going to coming up soon. This is really, really good talk. So there's a lot of comments coming through. I'm going to read some of them to you, and hopefully we'll be able to answer their questions. First is from Ms. Yan Tao. She said, amazing scientific and factual clinical information. So that's a wonderful to hear. She does have a question. She said that in terms of the home monitoring kit, the Binax, how accurate it is, and what about fake, I guess false negatives, and in terms of general, the quality of this at-home testings, how accurate they are. Can you answer that question first?
Yes, this is a very good question. Actually, home testing currently have two types. One is PCR test. Usually you check it, then you send out, and then after usually 1 or 2 days, they're coming back. Another test is rapid antigen test. So before we do have the find out rapid antigen test, usually is have the, they have low sensitivity when the patient is asymptomatic and compare with PCR test. And their sensitivity might only around 60%. When PCR test, if you collect very accurately, very deep in the nose all the way down, and that sensitivity is about 80%. Both of them have the specificity above 90 to 95%. So later they found out actually even your antigen test is negative, but PCR test is positive. At that time, people usually say, oh, antigen test failed. But on the other side, it may not be failed. Why to say that? Is because PCR test is very sensitive. They catch all the viral genetic pieces, even they are not infectious. So from current study, and antigen test really able to catch the face when people real infectious. That means if you run through PCR tests, they have to get CT level that their viral load up to a certain point, they are able to spread virus around contagious. That time, antigen tests become positive. So antigen tests will have the clinical value as they can detect clinically whether that is infectious or not, instead of you just detect like very small amount of virus or the virus left over, like a lot of patients, if you check antigen tests on later of their infection, they get better, they might be negative, but you check PCR, they're positive, but actually patients not infectious, they just have dead viral genetic pieces. So I think genetic antigen test from clinical value is real best for prevent transmission.
Right. In other words, if you're positive, unfortunately, if you're infected, then antigen test will be pretty accurate, right? So yeah. Okay, so more questions. There's a lot of questions. There's a questions here, a simple questions. Can the pregnant people use monoclonal antibodies for treatment?
Yes, monoclonal antibody is the antibody is just like their concentration of antibody. They are like blood product, but made specific. So yes, it's okay for pregnant patients. Yes.
Pregnant moms questions. Can you comment on COVID-19 impact for infants? Any preventive ways to minimize that risk?
Yeah, that's a very good question. So infants usually get from close contact, either their family member or if they go to daycare. Usually most babies, of course, except those babies have a lot of risk factors like sickle cell disease, they have congenital disease. Most baby, they have mild disease. Compare with children, like about 2-year-old, they still have a little bit more risk, be hospitalized, and but they usually is not as bad mortality as seniors. And unfortunately, this age have not able to prove to get any vaccination right now. And so usually infants can spread out. Actually, I have a lot of friends or cases like the little child get infected, then they shadow a lot of virus. So they spread to the family, a lot of family member, because they have to give their caregiver. You have to take care of those kids. So a lot of breakthrough infection.
Okay, all right, I hear that. So there's another question coming in, and this question is, in the death rate chart, non-vaccinated people and the breakthrough in 80 and 89-year-old group, the breakthrough is way higher than the non-vaccinated. How to explain that? This is from Mr. Chen Tong.
So I want to get back to this slides. So here, you can see actually, this is unvaccinated 80-year-old. And this is vaccinated 80-year-old. This is mortality, death rate. So you can still see actually for seniors, they are protected by vaccination.
It's just a round reading about the chart, right? The breakthrough is higher in the non-vaccinated group than the vaccinated group.
Yeah, so
kind of common sense.
Yes.
Okay, sounds good. And then the next question is Miss Alice Wang. She said that one of her family members has received IVIG and rituximab treatment for his autoimmune encephalitis, which means he's immunity compromised. Is there any test you would recommend for him to check on his immunity?
Yes, you can do antibody titer test before we talk a lot about it. We do have a lot of patients like on rituximab, chemotherapy, especially B cell dysfunction, like people with multiple myeloma, like General Powell is, they have very poor B cell function. So their antibody level actually is very low. So I think there's some value to check it to help you to know how much antibodies they will make if they don't, and might indicate I know monoclonal antibody can be given to this population if those population do have a post-exposure.
You know, the LabCorp currently do provide antibody titer checking for for vaccines. There's some other labs also doing that. Can you comment on the quality control? Is the reference range standard across all the testing centers?
That part I'm not very clear. As
Okay.
I know, most common we use LabCorp and Quest.
I hear you. Okay. All right. So there's another very good questions here from one of our audience. Great talk. And if we do boost shot right now, do we expect another one before the summer next year? That is a great question.
Yes, it's possible because from current, what we see, what we're facing is two things. One is after the vaccination, the antibody just went down. And it usually lasts about 6 max, like natural infections, 9 months. After that, antibody decreased. And so they are still able to protect against severe and critical disease, but they are not able to protect transmission and infection. And so also there's variants we're facing, like Omicron is coming. They have a lot of immune escape phenomenon. And so Pfizer and Moderna both trying to make specific booster to target those variants. I hope our pandemic can eventually stop, but with this things going on and on, it seems the variant is eventually, right now there's still whoever is more contagious, like Delta, maybe Omicron, even more than Delta, they're competing each other to get the dominant strain and in the society by infecting everybody, especially those unvaccinated. And in the future, they'll get more breakthrough, and then we probably need another booster after that.
Yeah, I think in this way, I got to ask for that question as well. I kind of like answer my friends and say, hey, you know, you get your flu shot every year, right? So it's very similar idea. We may not call the fourth one as the booster. We simply call, you know, another year pass, and then we just need to get annual shot. But the fingers crossed, because the third shot, the booster shot, did produce a significant amount of higher levels of antibodies than the first and the second, kind of like exponentially increase, and hopefully the antibody levels will last longer. A question similar though here, and from one of our audience saying that I finished the 2 shots in April, so it's 7 months now. I have not taken the booster shot yet. I think a lot of audience have that similar question. Should I take the booster shot now or wait a couple weeks to see if the current vaccine is good for Omnicron, since new vaccines will come out 3 months and have more effect to Omnicron? I don't know which new vaccine she's talking about, but probably she's thinking about a new Moderna, a new Pfizer one. And I wonder if I should wait for 3 more months to have the new vaccines.
It's a very good question. It's one of the most common questions right now I receive from, you know, different friends and the community. And so from there's 2 ways you look at this question. One is if you from public health point of view, I would say yes, get the booster because the United States is having another surge of infection. Personally, I'm a very conservative doctor. I usually prefer to not give patients too many medication. So if you go turn around, you look at personal point of view, personalized medical health care, then you should, for each person, you should evaluate their benefit and the risk. So who is real need a booster shot? One, I would say any senior. One is most of the senior, they suffer from the breakthrough, possible they still have high mortality. 2 is most of them do not have so much side effect. So the benefit is obvious over the risk. But for another population, for not senior, but you have risk factor, high risk, like you have hypertension, obesity, then get the booster. But if you don't, you're complete healthy, you feel very good, but you suffer so much from side effect, you hesitate. If you do not have high risk, like healthcare worker like me, I should have. But if you stay at home all the time, wear mask all the time, and you hate the second shot, previous, vaccination causes you so much side effect, you want to wait, I don't think there any problem. From each patient, you should think differently. Also, if your family do have high risk people, like you live with grandma, grandpa, or you live with somebody who have used all those chemotherapy, immunocompromised medication, I would recommend everybody in house, if possible, in order to keep your loved ones safe. Yes, get a booster, because very obvious booster can increase antibody and significantly decrease the chance of transmission. This is like different purpose of we use the medications.
I think this is a great answer. It is indeed one of the risk and benefits balancing. You have to consider your individual situation. I agree with you. If you have a loved one at home at risk, you're a senior or children's, and and you should consider. But like us, healthcare workers, we definitely will need to get one. But someone who stay at home all the time, you're completely healthy, you have limited social interaction with other people for the time being, maybe, perhaps. But I think one of the things I want to comment on is that, Dr. Wang, you have one of the slides showing that the side effects from the third shot is comparable to the second shot, or even less, right? So if you tolerate a second shot really well, I wouldn't worry about the side effects. Because a lot of people asking me, oh, will the booster shot give me more incidence of complications? But that's not true. If you look at this slides, if you tolerate well the second shots, you most likely tolerate the third shots well as well. It's less severe. Is that right?
Yes.
Excellent. Okay, let's just continue. Questions. There's just a lot of questions. Okay. So this question I'm not sure is accurate. So one of the audience said, if the vaccine does help, why the recent new COVID cases are 50% infected by people who are fully vaccinated? I think this is purely not a fact at all.
Yes, that's another question people usually ask. That's why I showed the previous slides. We were talking at the beginning of this lecture. It's all about that. Yes, you could be infected, but you can see how the vaccination can protect and decrease the mortality. So
and the risk of catch the infection as well.
Yes, they can also decrease the infection. And so vaccine is working. It's just a way try to decrease transmission and then get less people dying. That's what we're doing.
Exactly. So one of the data I wanted to share with the audience here is that at the Stanford University, I'm pretty sure across other hospitals in the country as well, majority of our hospitalized patients, okay, almost 99% of them are either non-vaccinated or immunocompromised. That is a really important data for everyone here in the audience to kind of digest that information. Okay, so let's just move on. And Dr. Wang, we also have a couple more questions here. So this is an interesting one. Are there studies that show how vaccination may lower chances of long COVID? Can you comment on that?
That part, I have not seen studies about vaccination change long COVID. I know vaccination prevent infection, and they they decrease significantly on the severe case. And usually most long COVID is related to, severe COVID infection. So currently I do not have that data. I have not seen a good study on it, but with decreasing the cases and decrease the severe and critical COVID, definitely decreased the long COVID effect. Clinically, my personal experience, I see a lot of patients are very, in the later coming back after they suffer from very severe COVID, be intubated on a vent for several months, packed, trached, then they end with severe weakness and almost paralyzed for 1 year almost. And
Wow.
so if you don't have severe COVID, you won't end with such a long term of complication. So I think to prevent getting COVID and prevent patient get severe COVID, that's how vaccine will contribute to the long COVID and to avoid it.
To follow up one of the earlier questions about the severe cases among unvaccinated for the seniors. Actually, he said his question was regarding the vertical bar chart named difference of severe and / critical COVID-19 unvaccinated versus the breakthrough. I think this is the one. I think this is the one. Yeah. This.
Okay. All right. It's because this is from Yale Medical Center. They totally have around 300 cases. So this is a limited study because the time range is just few months and it's in one medical center. And so this is what they're showing. But I think you should look in big picture. This is the whole United States in the last 1 year time. So I think that big population will speak more with the effect of vaccination.
So we're just the bias and deviations due to small sample size.
Yes.
Okay, well, that's indeed a very good question. Thank you for pointing that out and for answering that question. So again, for seniors, I think there's no question, no doubt about it, and that you need to be vaccinated as soon as you can. For 80 or 89, that's certainly included in this group. And the next question is, I think it's interesting. How come my antibody is at 2.3 instead of at the hundredths range? Thanks. And I think that has a lot to do. I think Dr. Wang is very clear. Either your body is not generating the antibodies, meaning that you may be immunocompromised, or assuming if you're healthy, maybe you know, a lot of time has passed since your last second shot, the antibody level has dropped down to the level that's almost non-detectable at 2.3. It's time to get a booster shot if you fall into this kind of a risk benefits categories of risk more than the benefit, risk more than, you know, more than the no risk. Okay, so we got another interesting question here. Is it advisable a third booster shot mixed Pfizer and Moderna? Meaning that if the first two shots were Pfizer, then the third shot should be used as Moderna and vice versa. Do you recommend that?
From current study, Moderna have a little bit better effect, yes. So when you have mixed match, although both of them are mRNA vaccine, but from current study data, they found out if you have a mixed Pfizer, 2 dose of Pfizer then plus Moderna have a little bit better effects than 3 of Pfizer. So I think you can consider, yes.
But if you have 2 Modernas first and then your third one, what would it be?
Still Moderna.
Still Moderna. Okay.
Yeah, Moderna have a little bit better, higher antibody level and lasting a little bit longer.
Okay. And I think the other question, I think we kind of answered that question. So he said that his cousin's son is coming to attend college in Boston. He received 2 doses of a Chinese vaccines. Oh, actually, this is a different question. So I guess the 2 vaccines from China, the inactivate one. Does he need a booster on arrival or should he check his immunity to determine a booster, but new 2 doses is needed? What would you recommend? What kind of immunity test? And have you seen any breakthrough cases from people who received the Chinese vaccines? Thank you.
Yes, that's a very good and very common question. Yes, currently, most universities suggest people previously be vaccinated with inactivated vaccine to, when reach United States, get another vaccine to be boosted. Yes, because from the study, inactivated vaccine, they produce actually much lower antibody, neutralized antibody level than the mRNA level. It's like more than 10 times difference. I personally didn't really get any case have breakthrough because I just encountered such a limited population who received the inactivated viral vaccine. And but when you have the mix and match study, I believe recently by our famous Dr. Zhang Wenhong, right? The Zhang Hongwen, and he did the research on inactivated mixed with Pfizer, and they found a significant difference to the booster shot to get improve the antibody level. Okay. And to prevent the transmission. And so on those cases, United States is a high risk area. We have virus everywhere. Yes, they should be boosted. Yeah. I don't think they have to check the level because from average, the level is usually very low.
Okay. We have a lot of questions coming in, but I don't know how long I can keep you here. One of the readers commented that this is one of the most informative and valuable COVID seminars among all the public and private ones. Thank you so much for liking our seminars. But he said, I was too busy between reading the graphs and listening and have probably missed some of the info. Can we have a recording, please? Yes, this seminar is recorded and it will be hosted by our faculty club. And he said, what is the long COVID percentage among infected? Do you have a rough idea?
Yes, actually I have a slide. For long COVID, so for the people who infected with COVID, they have long-term effect. So recently have summarized analysis of all the studies about long COVID in different countries, the percentile of the long COVID. So there's like more than 20 studies here. So they have a wide range of how many people get long COVID, like they lost their taste, they depressed, they're very fatigued, and all those things. And so you can see the range from 10% to 80%. And so the average is 45%. If you get, COVID symptomatic, you have like 45%, you could get long COVID.
Mm-hmm. Yeah. I think we got this question. You kind of answered it before. You said when the middle-aged, otherwise healthy person got infected, how can he or she ask for the monoclonal antibody, as soon as possible? I think, is the doctor only prescribing this to seniors? I think you kind of indicated already, it's really just for certain people, high-risk people.
Yeah. So mid-age, if you have chronic disease like lung disease, liver disease, those high risk currently is indicated. Even young people, if you have risk factors, they are listed on if you Google search like CDC, FDA, they have that list. If you meet that criteria, you can get it. And it's just, you need to aware this is available. And unfortunately, it's not open to everybody. Yeah.
So the other two questions are considering about the vaccine. Any comment on J&J vaccine? I did notice that we didn't talk about other vaccines at all today.
Yes. So JJ, right now, JJ have original efficacy about around 78, as I remember, 75 or 78 of percentile efficacy. Then with 6 months, they decreased, as I remember, decreased close to 40%. And so JJ, anybody get JJ, more than 4 or 6 months ago, especially 6 months ago, they should be boosted because JJ do not last very long, and their their efficacy originally was not very high. So JJ is usually, as everybody know, could have a little bit more chance cause in young female have blood clots, and but eventually FDA still proved it. So this is, I can think about JJ vaccine.
Yeah. I guess the other questions is that we know one audience that, oh, why would we need to get this vaccine shots multiple times comparing to many others? I think it's pretty clear because we know that the protection provided by the vaccine tend to decay over the time. Actually, that's the case for most of the vaccines. We may have a false impression that one shot that lasts forever. That doesn't do. Right, your influenza, your flu vaccine, your herpes, shingles vaccine, and the pneumococcus, you do need to get it from time to time because those immunities don't last forever, and etc. Perhaps hepatitis B, that's a different story. I think it's a completely different kind of category. Let's just get to the last questions, and I think we still have over 110 audience. At the higher peak was 130 plus. Audience is really interested. Dr. Wang, I wanted you to answer one more question before I let you go. So this is an interesting question. So the audience asked, can mRNA vaccines cause some long-term effect on human body, such as changing your biodynamics in the body? Some people still worry about mRNA can cause mutation, birth defects, etc. And he put a smiling face in the end. I think a lot of general public do have that kind of a, it's not something familiar with. So how would you take on that kind of questions?
Yes, up to now from all our research and from, so this mRNA vaccine, when you inject it, they do not get into nucleus. This is what current research tells us. Then a lot of people still don't believe it because they said that this vaccine is only used for 1 year. How after many years? And especially they worry for their young kids after receive this vaccine. For the future, what will be, nobody can tell. But I can tell you up to now, United States already give 200 million doses. And you can see how this is one of the vaccine in the history in the whole world, and it gives so many people and such a big spectrum of people. But how much side effect you are seeing right now after 1 year is still not as scary as what we saw before. So I think the fact is tell us this vaccine is really helping us, help a lot of people to avoid with fighting such a long pandemic and to survive through it. And the significant side effects have not shown, even used in the whole world, it's millions or even billions of people. So I think it's still very safe and reliable.
I agree with you. And then for the audience, if you have not got your immunizations yet or your third boost shot, which you should get, and feel free and then feel safe to go get one. Dr. Wang and myself, we all got ours already. So Dr. Wang, so on behalf of Stanford Chinese faculty and family, we wholeheartedly are grateful for your wonderful, wonderful talk today. And all our board members are here. Dr. Cui, would you like to say something before we let Dr. Wang go?
Yeah, thank you so much, Dr. Wang and also Xiang for this amazing webinar. I myself learned so much, even though I have a lot of exposure to knowledge at Stanford already, but I learned tremendous in your talk. From the audience questions, you can see You really help answer a lot of their concerns. Thank you so much. This is very educational. With that, let me close this webinar. Let me thank all the audience for spending the precious Sunday with us. Thank you. Bye now.
Thank you, everyone. Bye-bye, Dr. Wang. Bye-bye, Che. Bye-bye, everybody.
Bye.